So we'll get started now. So today, guys, I am interviewing Dr. Haydee Brown. She is an orthopedic surgeon in New York City, and she is a good friend of mine and just someone I really look up to and admire. And especially, she's a colleague, an orthopedic colleague, and we all know each other from our circles, from our meetings, and just the fact that we're in the same specialty. But now with the COVID-19 pandemic sweeping through New York City, and we are in the middle of what they are calling the surge. And a lot of these hospitals are at capacity and really calling out for volunteers and need for additional physicians. And so Dr. Brown, actually, she had shut down her practice and is now volunteering on the front lines of COVID-19 care. And I think that is absolutely amazing. She's putting her safety, her family's safety on the line. So Dr. Brown, welcome. And can you tell us a little bit more about why you decided to volunteer?
So hi, everyone. Good to see you again, Dan. I decided to volunteer because I was actually feeling pretty helpless with the COVID-19 response. As orthopedic surgeons, we more accustomed to taking people that are hurt and making them better pretty immediately. And there's a very limited role for our specific skill with this COVID-19 response. And I saw that there was a call for physicians and decided to volunteer. It was actually a very fast process. The Medicine Reserve Corps the Medical Reserve Corps has really done a fantastic job with getting healthcare workers credentialed and linked up with hospitals that need them the most. So I started to volunteer. Basically over the course of a weekend, they credentialed me for a hospital here in New York, and I started volunteering on that Thursday.
Wow.
My role has been, twofold. First, I was on an ICU floor, on a medical floor that was converted to an ICU floor, just because the majority of these patients are very ill. And then I moved on to be in the ER, which I have a bit more of an inactive role in helping with patient care.
Wow, I see. You told me a little bit about the medical floor being converted to an ICU floor. Do you mind sharing a little bit more about what you saw there and how quickly they had to adapt to the surge? You talked to me about drilling holes in the walls, whatever you're comfortable sharing with what you saw on those medical floors.
So these units are incredibly strapped. Medical floors are one thing, an ICU unit is something else, meaning the way that the infrastructure, meaning that you are able to see patients very clearly, you have monitors, et cetera, and usually a smaller number of patients under a team's care. Given that coronavirus has really kind of decimated our city, the unit floor I was on was a floor that adapted. Apparently it had opened 4 days before I was there, being converted from a regular medical floor to an to an ICU type of floor. And the hospital adjusted very quickly. They put video cameras in each room so they could keep a feed on patients. The patients were placed on portable monitors so they could see the monitors from the portable camera. They drilled holes in each of the room walls so that it could create a safer environment for the workers to take care of these patients by keeping all of the lines and IVs and pumps outside of the room.
Wow.
And the team was working incredibly hard, and these are very, very ill patients. I would say of the 30 patients on the floor, 25 plus were on ventilators.
Wow.
And young and old, healthy and not healthy and with comorbidities. And the team's just working really hard to try and take care of them and keep them going.
Wow. What was the biggest challenge in that kind of setting where 25 to 30 very ill patients on ventilators? Was it the amount of staffing that you had? Was it the fact that you had to throw on PPE every time you had to go into the room? What did you find, or was it all of it? Was everything kind of a challenge? So,
I think it was all a little, maybe even a little overwhelming at first. I knew that I would be volunteering. I didn't necessarily realize that I would be on an ICU floor to start with, but there was enough support staff there, meaning there's the critical care physician as well as residents to work with, that there was nothing that I needed to perform that I was not comfortable with doing, particularly being this far out of training and being in a critical care setting. I think some of the challenges were just there's just a lot of patients. There are a lot of very, very sick patients, and the hospital systems are creating room to house them in, but those rooms aren't necessarily the best rooms for critically ill patients, and they are adapting and being creative in how to make that happen. It was a challenge to monitor all of those patients on the video feed and keeping, and granted, we divided up the work, but just keeping abreast of any of the changes on the monitors because this was a newer ICU kind of layout. But and the PPE, it's a lot of PPE, the mask, the hats, the gowns, the double gowns, the double gloves. And these are critically ill patients. So sometimes people are running into the room and then coming out, and you've got to pull that off and you're sweating, and then you've got to go into another room. And really the logistics of properly donning PPE can be a little onerous, in particular for the trainees that are, they're working up to 80 hours a week. They're working incredibly hard under and adapting in this. We had residents that weren't necessarily even general surgery residents or internal medicine residents that now are working on these ICU floors because they've been redeployed and adapting, and that each day the recommendations seem to change. Each day we're learning more and more about coronavirus and how or an attempt to optimally treat these patients. So, one day the patients are decompensating on the floor and you're concerned about whether they're getting the proper oxygenation. You start reading more articles that are literally just posted that morning or the morning before in our medical journals. And then patients seem to do better when you're proning them. So now we're all proning patients more. It's a very fluid, rapidly changing environment to treat patients in. And that's not always how we're accustomed to functioning in medicine, especially in orthopedics.
Absolutely. I think I read somewhere that the typical medical advance takes, somewhere around years for physicians to really buy into, right? Or there's some advance, or there's some recommendation to the treatment algorithm, and it takes years for us to implement that. Here, we're talking about hours, right? It's something you hear on social media or gets distributed, and that's the power of social media, right? You were transferring information from Italy, from China, and literally, we can't run these randomized controlled trials here. It's prohibitive, but at least we can get some sense of what's working for physicians and try anything to save these patients' lives. So, that's a very interesting thing you note. What are you seeing in the emergency room? You say you did a shift in the ER. Is there anything there that you want to talk about that you're seeing in the emergency room?
Absolutely. Now it's a bit more in the press, but the majority of the patients that we've been seeing are Black and brown, so Latino and African-American or of African descent. And anecdotally, there's this clinical picture of a healthy individual, male in his 40s or early 50s, who comes in with the coronavirus picture, which is cough, shortness of breath, fever for several days, maybe change in taste or change in smell, and they appear more or less okay. They're not in a serious amount of respiratory distress when they come in. And then you support them with sort of minimal oxygen support, and you build up as you need to, but they decompensate incredibly quickly. And there seems to even be a small group of indigenous Central Americans that follow that profile. They appear pretty healthy and without a history of diabetes, but when they present, their blood sugars are incredibly high, and they're working very, very hard. It's a very stoic population. They're working really hard to breathe. Wow. And then eventually you can't breathe that hard. And so they end up getting intubated. So that's been tough. That's been definitely tough because you're trying everything to keep them off of the vent. Not because you're conserving vents per se, but because once you place a patient on a vent, they're following a different trajectory, one that we don't entirely understand yet. So it's a patient I took care of recently definitely stuck with me, but I'm glad to see that he is still doing okay being all relative. He's still alive, which is important. But he's another person that, was just a very young, healthy individual that then just, the start of the shift, we're talking and even joking while he's on oxygen supplementation. And by the end of the shift, we are rapidly putting a tube down his throat and putting him on a ventilator.
How many hours was that from the time you spoke to him to the intubation in that shift, if you remember?
6 hours.
6 hours. Wow. That's, I can't even imagine, seeing that. We don't see that kind of stuff in orthopedics, obviously, that.
No.
It's hard. This whole oxygenation issue, I listened to a podcast by James Kai on the New York Times Daily. He was the physician assistant about 3 weeks ago in New Jersey at Hackensack. He had been the first case of coronavirus.
Oh, wow.
He's a medical professional, so he was talking about it and also describing it when he had the ground glass opacities on his CAT scan and the pneumonia that was picked up on the CAT scan. He basically described it as a feeling similar to drowning, where he said, you tried to take enough, you're trying to take in all this oxygen, but you just can't. It's not that you don't want to, but it's like that feeling of being underwater and not being able to draw on that breath. And I can see how that is just, you have a tremendous amount of those patients coming in. It's a hard situation. Yeah. What do you want to tell maybe our elected officials and our kind of decision makers? Because there's so many things we can't control on the front lines, right? You're there trying to save lives, help patients. And a lot of, what ends up in the ER or whatnot, the social distancing is not something we control. It's something that, our policymakers control and decide. And then that ultimately we have to bear the brunt of those kind of decisions that are made from above us. What do you want to tell our policymakers here about what you're seeing on the front lines and what you'd like to see happen different, or, encourage them to do more of?
So it seems like the valve is opening a bit for PPE, but to encourage supplying our healthcare providers, physicians, all the way through respiratory therapists and janitors, the proper protection so that we can do our jobs. Understand that each of us there represents a family of people. And I'm going to work. I'm not being compensated for that work. I enjoy the work that I'm doing. But I also have a spouse and a child and a family. And so I'm taking extra precautions to try and be as safe as possible. And the hospital is providing the PPE, but you see there's a lot of variability throughout the hospital system. So that's concerning. Something else that I would add is that there are a lot of us independent physicians who want to help on the front line, but understand that in moving away from one's individual practice or group practice, you are taking on a huge risk that can have serious downsides for your family. So to ensure that we have some protections, whether it's just workers' comp for physicians volunteering, or some form of an insurance policy that if anything happens to us, that our families are supported and cared for, because we all enjoy what we're doing. We similarly are scared like the general population. It's just that we're able to have a skill that can help fight this, but we want our families not to bear the brunt and the sacrifice of the work that we're doing. And then lastly, I would say that we really need to be aware of the supplies, not PPE supplies, but the supplies to take care of patients. I'm glad to hear from the most recent reports that there seem to be enough vents, but something that was happening a lot is that the oxygen tanks are running out in the ER because these patients they're very sick. And so normally you have one of your little portable oxygen tanks and you can have a patient on that for a while they're in the ER. And sometimes, as we know, patients can hang out in the ER for a very long time, days sometimes. But with these patients, they're so sick that they're burning through these tanks very quickly. And so it's another layer of observation that you need to do, in addition to making sure their labs are drawn, making sure that they have all the components for us to make sure we're taking the best care of them. And we have people literally, since there's so many patients and not all of them can be on monitors, we have people that walk around basically doing rounds every, interval of time where they're checking every single patient's pulse ox. And at first, when we would see desaturations, at least my colleagues were saying that they would immediately try to move towards more move towards supporting them more, whether it's placing them on vent or on BiPAP or what have you. But now the default is to say, wait, first, let's check the oxygen tank and make sure that it's full.
Yep.
And now if that's not working, then we'll go through the other steps. And that's just, again, we're adapting. We're learning that these patients require so much more in terms of oxygen and so much more support that we are kind of burning through what our traditional tools are. So more now you're seeing the larger tanks in the ER being used for patients as opposed to the small portable ones that fit on the bed. And very specific about which patients you're trying to place in which area of the ER that has the wall oxygen, because if, for example, one of my patients hardly needed oxygen when he first walked in, and then we had him on a portable tank, and then he needed the larger tank, and then we had to transfer him to another room with wall oxygen because that's how, I mean, he's on a vent, he needs that. So it's just to ensure that we have those supplies, in particular oxygenation. We can't make up oxygen tanks. We have to have those supplies in-house, and they need to be full and replenished promptly.
Yeah, you know, Dr. Khan actually last night when we did our Q&A mentioned the exact same supply issue, that they've been asked to conserve oxygen at her hospital. So, you know, hearing it from a second physician, this is a real issue, and you know, I hope that whoever is, you know, kind of working that supply chain can figure that out for us to get oxygen. And you know, there was a report also, I think recently, that propofol was actually, you know, which is a medication that's used to sedate patients who are on the ventilator. There's a shortage of that. So it's not just the ventilators, there's a shortage of everything. And that's one of the things, I guess, you know, we have to start implementing, you know, into the decision-making process, which we're not used to as healthcare workers and, you know, as physicians in the United States. One thing that I do want to let our viewers know about, if you're comfortable, is you also have another person in your family who's volunteering. Is that correct? Can you tell us more?
Yeah. So my fiance is actually a fireman here in Harlem, and they have their standard shifts, but the FDNY, rightly so, is being very specific about who can work in which firehouses to try and keep any infections to a minimal level. And so he's been, I mean, he's been volunteering to do more shifts. Wow. I think we in medicine, I remember in training, I worked 24-hour shifts every 2 days for stretches of at a time, and it was grueling. And I don't even know if I remembered my name at the end of those stretches. But he's working 24-hour shifts every other day.
Wow.
Yeah,
wow, really?
And that he noted maybe there seems to be a bit more activity. That they hear overhead, of course, FDNY, all the calls for cardiac arrest, for doing CPR in the field, and that given that that's overhead, you're hearing that all day, whereas before maybe you'd have one or two for a 12 or 24-hour shift, and now it's almost a drumbeat that you're hearing that. Something else is that levels of violence, you know, domestic violence have gone up. So they were returning from a run recently and ended up breaking up a guy that was beating up his partner. And also that since so many more people are home, there are simple things like small stove fires and people are getting stuck in elevators. And the thing about being a firefighter here in Harlem or in a community that's poor is that they're not going to call their super to come fix the elevator, right? If people get stuck in the elevator, they call the FDNY and they have to come and get them out. Wow. So that's happening more frequently. And then, I mean, some of them are getting sick, right? So they're having to pick up more and more work. And it's just a phenomenal group of men and women in the FDNY that really are so incredibly giving. And any information that I learn, what new vitamins I'm taking, or I'm taking probiotics and something else, I tell him and he tells his firehouse, and then they share it amongst firehouses, so that we're all just trying to share the knowledge that Dan and you and I are able to get from the medical literature and listening to podcasts, et cetera. These guys are literally on the front line, fighting fires, getting people out of, you know, horrible situations, and may not be able to follow all of the minutia. So I tell it to them, like I made them all I demanded that he wear a mask, which he really didn't want to at first because he felt like it would intimidate the people you're helping, but he needs to wear a mask going to and from work, and he finally does it. Or the frequent hand washing, they have huge bottles of sanitizer there now. And although this is counter firefighter culture, I really have recommended that they try and socially distance in the firehouse, which is counter fighter culture whatsoever. I mean, I've been there before. We like sit in the firehouse and eat dinner or lunch together, literally next to each other. And that's really not the best thing for social distancing. So they've got a big firehouse. And so encouraging them to spread out more. I spoke to one of the chiefs about that. So just trying to infuse some of our medical knowledge into their culture and see where it matches up best, where they can still hold on to the things that make them, New York's bravest, but also make sure that they're still around.
Wow. I mean, I could just tell, what you're talking about is you are just a very results oriented, action oriented individual who you want to take action, and you want to make sure that, whether it's with your own words to your fiance to affect his firehouse, or whether you're actually charging into the hospital to be on the front lines, to risk your life and also your family's life. I have to say, you're a hero, and you're a hero to me and all the New Yorkers. And, I thank you for your time today that you spent. This is your off day. You need to get some rest. And we just want to get the story out to as many people as possible. But thank you everything for your doing, Dr. Haydee Brown. Appreciate it. And I'll talk to you soon. Okay.
All right. Thanks, Dan, for everything. See you soon.
See you soon.
Bye-bye.
Bye.